welcome to the Applied Radiology Expert Forum on Clinical Applications of Positron Emission Mammography. I'm Kristen Boland, Executive Editor of Applied Radiology, and I'll be your moderator today. I'm pleased to welcome so many participants to this one-hour educational webinar. Now, the goal of this webinar is to provide you with actionable information you can use in your clinical practice today.
It's also to discuss clinical indications for PEM and PEM-guided biopsy, as well as to describe performance characteristics of PEM, including sensitivity, specificity, and PPV of biopsies. With that, I'd like to introduce our panel. Our guest speaker today is Dr. Wendy Berg, who is a visiting professor of radiology at the McGee Women's Hospital, University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania. Dr. Berg has 18 years of experience working with PEM, or high-resolution breast PET, and has published many papers on this and related topics. In the question and answer portion of our webinar, immediately following Dr. Berg's presentation, we will be joined by Dr. Kalaniak, who is Chief Medical Officer of Naviscan. I would like to take this time to thank our corporate sponsor, Naviscan, for making today's webinar possible. Now, after the presentation, we will begin a live panel discussion. Feel free to submit questions for the panel's consideration at any time during the presentation using the question option you'll find in your GoToWebinar dashboard. Please note your question window may be hidden behind presentation window. So if this is the case on your monitor, please just move or minimize the presentation window to access the dashboard. So without further ado, let me introduce Dr. Berg. Welcome, Dr. Berg. Would you please take the controls?
Thank you, Kristen. It's a pleasure to be here this afternoon. I have consulted for Naviscan and been compensated, and here's my disclosure. Today, we're going to talk about molecular imaging of cancer, and specifically breast cancer. The indications for this include initial staging of women who have newly diagnosed breast cancer, predicting and monitoring response to treatment, and finally distinguishing scar from recurrent tumor. At this time, we don't have data specific to PEM on the last indication, although there are published papers looking at this with PET, and certainly we know MRI has been used in this regard, and pretty much indications that we would consider for MRI in women with breast cancer, we would also consider PEM as an alternative, and I'll talk you through the studies that we've done in that regard. PEM uses fluorodeoxyglucose, which is an analog of glucose taken up by metabolically active lesions, including breast cancer. And when we talk about staging, which is really the thrust of most of the work that we've done in this area, and local staging in particular, we're talking about several issues. The first is the ipsilateral breast with the known cancer, where we want to, of course, ideally map out the size of the cancer as well as any additional tumor foci that may be present in that breast that might direct the surgeon to perform mastectomy. And this really is pre-surgical planning or pre-treatment planning. We're also, of course, interested in the contralateral breast. I think with the results of the ACOSOG Z11 trial, we're less interested in the axillary node status, but we can discuss that if there's interest later. And finally, with whole body PET, of course, there's the option to look at systemic disease. And I will just mention that one thing that is possible is to do whole body PET imaging followed by PEM with the same injected dose, although that may not be reimbursed, but it's something worth noting for the future. And then finally, I think a very exciting area for PEM especially is to look at response to neoadjuvant chemotherapy. So these would be patients where they would be imaged prior to treatment as well as after, for example, one cycle of treatment to determine whether or not their tumor is in fact responding, and if not, to consider a change in the chemotherapy regimen, and then finally to look at the disease extent again prior to surgery. And certainly there is a need for better options in this regard, although MRI again is being used for this, and certainly we need more studies in this area. When we talk about ipsilateral disease extent, we are considering really several issues. One is the size of the known primary cancer, as I mentioned, but we're also interested in looking for multifocal or multicentric disease. Multifocal tumor is usually defined as separate tumor foci within the same quadrant of the breast, usually within 4 or 5 centimeters of the primary lesion. Sometimes it's defined as being along the same duct system. Multicentric disease is usually defined as separate foci in different quadrants or at least 4 or 5 centimeters apart. And usually patients with multicentric disease historically would be treated with mastectomy. Here's an example of a PEM study. So and I'll talk more about this, but we get 12 slices that are tomographic of the breast, and it really provides rather exquisite detail. This patient had a known cancer, but you can see that there was much more extensive disease in a segmental distribution, and this is multifocal invasive ductal cancer here, as well as an extensive intraductal component. And there was yet another focus of invasive cancer in a different quadrant, so this was multicentric as well. And appropriately, this helped to guide the decision to perform mastectomy. It's quite common that there's additional unsuspected disease when we look hard enough. And this is a matter of some controversy, whether we need to find all this or not. And again, we can discuss this if there's interest. But Laura Lieberman had a nice article looking at MRI performance and reviewed the pathology literature. And across the literature, there's a 48% rate of additional unsuspected tumor foci if you look hard enough at histopathology in women who had a mastectomy but were thought to have a single focus of cancer. And as Roland Holland and colleagues showed many years earlier, the vast majority of those additional foci are going to be in the same quadrant, multifocal disease. And MRI has been shown to be effective in finding many of those additional foci. There was a nice review of this issue that Neema Husami and colleagues put together in 2008, looking at 19 studies of MRI in the evaluation of ipsilateral disease extent, showing that additional cancer was found in 16% of women, that the additional biopsies that were prompted by MRI, 66% were malignant, and that overall there was an 8% conversion rate from wide local excision to mastectomy, and another 11% of patients had a wider local excision than was originally planned, and that was all good. But unfortunately, there was also an inappropriate rate of mastectomy in 1% prompted by the MRI, and excessively wide local excision in another 5%. This highlighted the need for a more specific test that would be less likely to prompt unnecessary surgery and especially unnecessarily harsh surgery. And this really was where the interest in looking at PEM for this purpose came about. So PEM, or positron emission mammography, uses a dedicated high-resolution device. You can see the field of view is about 23 by 17, which is comparable to what we have with mammography, although there are going to be some large breasts that require additional views. We use 10 millicurie dose of FDG at present, although there are some preliminary studies suggesting 5 millicurie dose may be comparable. The patient should be fasting for 4 and preferably at least 6 hours prior to the injection of the FDG. And we do want the blood glucose level checked right before injection. It should be less than 140 because it will compete with the FDG. And it's often possible to have the patient come back a little later and the glucose will be in the right range, but it is something to be aware of. We typically will allow at least 45, if not 60 minutes circulation time after injecting the FDG, and that's actually very important. Waiting even longer may be even better in terms of tumor to background ratios. And again, FDG is taken up by metabolically active lesions, so you will see uptake in actively dividing fibroadenomas, inflammatory change, some papillomas, and some atypical lesions as well as cancers. Here is a picture that shows the device. It's very similar to mammography, except that the breast is only subject to very gentle stabilization. It's not tight compression. The compressed breast thickness is typically in the range of sort of 5 to 6 centimeter, sometimes even more. And we do position the breast similar to mammography with routine CC, craniocaudal, and MLO, medial lateral oblique views of each breast, with additional views as needed, especially if it's a large breast or there's a very posterior lesion. You can do the same type of positioning as we do for mammography for extra views. Here's just an example showing the difference in resolution between the whole body PET on the right and PEM on the left. You can see much more exquisite detail with the 2 millimeter resolution of PEM compared to the 6 to 7 millimeter resolution of whole body PET. There is radiation involved. Again, this is with a 10 millicurie dose, and this is from Ed Hendrick's paper in Radiology in 2010. But you can see it's a whole body radiation dose rather than just to the breast itself. And the dose overall is comparable to that of a chest, abdomen, or pelvic CT. Now, in a woman with newly diagnosed cancer, this is not considered a problem. However, this does speak to the fact that we're not advocating PEM for screening at this time, especially at that dose. Here is a nice example of a patient who has a known cancer behind the nipple, not very well seen on the mammogram, and you can see the 12-slice tomographic PEM image here. The labeling is such that medial lateral oblique, this first slice is the medial, the last slice is the lateral, and here we have the known cancer as well as multiple additional foci of disease in a large area, segmental distribution, and this was again high-grade multifocal invasive ductal carcinoma. We also can see DCIS with PEM, and here's a patient who had a palpable abnormality, a little vague asymmetry on the mammogram, very nicely shown as multiple foci of disease on PEM. Here's another patient who has two masses, one in the right breast and one in the left, that look relatively similar on mammography, but importantly on PEM, only the cancer shows uptake, and this was an invasive lobular carcinoma, whereas the fibroadenoma does not show uptake in this particular case, as this is functional imaging, of course, rather than just strictly anatomic. So we had actually published an initial series involving women who had lesions that were considered suspicious on conventional imaging, either mammography or ultrasound or both. And in that early experience, we showed a very high sensitivity of PEM of 90%, as well as a high specificity of 86%. And remember, these are all lesions going to biopsy. And the PPV of a biopsy that was prompted by the PEM findings was 88%. Further, there were a few cancers seen only on PEM. So these very encouraging results prompted the development of a multi-center protocol. And here's just a summary that shows that we saw DCIS very well on PEM, 91%, as well as even the small breast cancers, even under a centimeter in size, were seen relatively well also. And here you can see that with implants, that's not a problem. As you might expect, we were able to see this case with multicentric disease, very tiny additional focus of invasive cancer, unsuspected on conventional imaging. And as I mentioned, the most important issue was the reduced false positives. We had, with conventional imaging, over half of lesions that were benign looked suspicious, whereas on PEM, only 12%. As I mentioned, some fibroadenomas, papillomas, even fat necrosis will show uptake of FDG. So there are those false positives even with PEM, but it's much less frequent than with conventional imaging. So, as I mentioned, these early successes prompted the development of a multi-center trial looking at PEM compared directly to MRI in pre-surgical planning of women with newly diagnosed breast cancer. This was performed at 6 sites, and this was published in Radiology in January. And I will point out that all these women were considered candidates for lumpectomy surgery by a surgeon, and I'll go into the specifics of that, but it means that they had smaller disease, relatively speaking, compared to some of the other literature that you might run across. And importantly, the exams of the PEM and MRI were performed independently of each other in randomized order, separately interpreted, blinded to the results of the other examination. Here's an example of one of our participants who had relatively dense breasts mammographically. You could see her cancer had multiple calcifications within it, and here it is on ultrasound as well with epigenic calcifications. This was a high-grade invasive and intraductal carcinoma. This particular patient had an MRI here, which had multiple additional lesions in it, and here was her known cancer, but there were additional foci in both breasts that were considered suspicious that underwent biopsy, with each of these additional abnormalities proving to be benign. And her PEM study appropriately just shows the two little satellite lesions, which was just an extensive intraductal component adjacent to the cancer, and none of the additional false positives that were seen on the MRI. And here she also had a whole body PET study, and on that you could see the primary cancer, but you don't get the additional detail that we did on the PEM. So in the middle are the PEM images, first in black and white and then in color, just showing again the detail that you see behind the cancer with the satellite lesions, which does help the surgeon to obtain clear margins in this case. So in the main protocol, there were 388 women who were able to complete the testing and did not have neoadjuvant chemotherapy or other exclusion criteria. Median age 58, and importantly, the primary tumor size median was estimated at 1.5 centimeter initially. 82 or 21% of the women had additional foci of ipsilateral tumor identified after study entry, which is quite comparable to the 16% average that you saw with the MRI meta-analysis. And those additional tumors were small, median size of only 5 millimeter, although there was quite a wide range. In order to be eligible for the protocol, as I mentioned, women had to be candidates for lumpectomy surgery. This meant that they had a diagnosis of cancer by core biopsy, but also that the cancer was confined to one quadrant and was felt to be less than 4 centimeter on review of the pre-study conventional imaging of mammography and ultrasound if ultrasound had been done. We did allow up to 5 centimeter in a very large breast, specifically over D cup in size. And the tumor could not be involving the skin or nipple and could not be known to be multicentric. And again, I think it's very important to have prospective criteria if you're considering designing trials yourself. We also tightly controlled the interpretive criteria as well as the qualifications for the investigators. So all of our physicians who interpreted PEM studies as well as MRI met all experience requirements of the Mammography Quality Standards Act for mammography interpreting physicians. They also had experience interpreting at least 50 breast MRI examinations, and all facilities had to have availability of MRI-guided breast biopsy. For PEM, these investigators also had to undergo a 2-hour training session, which is a PowerPoint presentation that's available from Naviscan. This includes a training in image display and interpretation. It includes material on the PEM lexicon, which was actually just published in the AJR in April this month, and also included a quiz on PEM cases as well as MRI cases. And that also was published, the results of that were published in AJR this month. And here is the interpretive skills test, just to show you that actually, despite the fact that these investigators essentially had no prior experience with PEM, they were able to quite easily learn how to read it. And here is the ROC curve just showing very, very high performance on the PEM interpretive skills task compared to MRI. Now, mind you, these were different cases. The MRI task was the one that had been developed for the Akron 6666 protocol. But bottom line is that it was easily learned to interpret PEM and with high performance characteristics. We also showed, importantly, that it was reproducible, that the interpretation of PEM was consistent. And this, again, is important for any new technology. And again, in the interpretive skills task, we showed that the overall agreement on final assessment was quite high at 0.63 for kappa. In our analysis, one thing I want to point out is that many of the prior studies of MRI, which make it sound quite good, actually include the known cancer. And we felt that this was a bias for several reasons. Obviously, you already know about it, so finding it is not anything very useful. And secondly, we also knew that inflammation from recent biopsy could cause a hotspot, so we didn't want to give credit to PEM just because there were post-biopsy changes. So we excluded lesions that had been biopsied prior to study entry. We did use an expanded BI-RADS type scale, as you can see here. And here's a patient who had a palpable cancer here, and on the PEM study, you could very nicely see a second focus of malignancy in a different quadrant. The same findings were confirmed on MRI, and there was also a small focus at the nipple, and so she then appropriately had mastectomy. Another patient who had about a 3-centimeter area of pleomorphic calcifications on mammography was thought to be a candidate for lumpectomy surgery, but when we did the additional imaging, you could see with PEM and with MRI that there was much more extensive disease over about a 7-centimeter segment, and so then she also appropriately had mastectomy. So this is an important slide, and interestingly, we found that PEM and MRI are complementary. There's nothing simple about what we do. I mentioned there were 82 women who had additional tumor. Of those 82 women, we were able to see overall 34% with both PEM and MRI, 26% only on MRI, 17% only on PEM, and importantly, there were some cases, 8.5%, that were seen only on review of conventional imaging. So overall, I just want to point out that that's only about 60% of the additional tumor foci were seen on MRI, which is not that great. But that is comparable to the paper that Sardanelli put together years ago, where with detailed sectioning at histopathology, there's actually a fair amount that's missed on MRI. And this is maybe one of the reasons why it has been less able to reduce positive margins, less able to have an impact on the surgical management of disease, and perhaps may not affect recurrence rates. With PEM, overall there was a 51% detection rate of the additional cancers, and remember that these are mostly not seen on conventional imaging, so there is a substantial benefit to either PEM or MRI in terms of seeing additional cancers compared to what you see with just mammography alone. And then also, it's important to recognize that with conventional imaging, some static or something, that with conventional imaging review, we were able to identify additional tumors that were actually on the mammogram. So having the person who's interpreting the PEM also be a person who's a breast imager who can look at the breast imaging with the PEM is actually going to be very important to improving overall performance characteristics. So at some centers, I know nuclear medicine physicians are involved in the interpretation, but I would just encourage any centers that are doing PEM or contemplating doing PEM to also have involvement of the breast imagers at a minimum. Of the additional disease, this just summarizes what I just said on the last slide with respect to MRI, overall 60%, PEM 51%. This was not different at the breast level, although at the lesion level, MRI was very slightly more sensitive than PEM. And again, they're complementary. So the two together, we saw 74% of additional disease. And if you added the conventional imaging review, 83%, well, then that still left another 17% or 14 women where we didn't see all of the disease, even after all of this additional testing. Importantly, we mentioned up front that one of our goals was to determine whether PEM was more specific than MRI, less likely to prompt unnecessary surgery, less likely to prompt unnecessary additional testing. And we did, in fact, succeed at that. We found that overall 86% specificity with MRI compared to 91% with PEM, and PEM was indeed significantly more specific. Obviously, since conventional imaging missed most of what was there, it's the most specific, so there are some trade-offs no matter how you look at this. And overall, because of the increase in false positives, along with increased detection, the overall accuracy is the same for any given approach, so there are these trade-offs of false positives to pay the price for the increased detection. Here is a patient who had a known right breast cancer, and the MRI not only didn't show the known right breast cancer, but it had a false positive fibrocystic change in the left breast. In this case, the PEM nicely showed the known cancer, but there were no false positives in the left breast. When we look at biopsies that were prompted by additional imaging, overall there were 211 lesions biopsied, of which 55% were cancer. If the lesion was seen only on conventional imaging review, 60% were malignant. 41% of biopsies prompted by MRI were malignant, and 55% if the lesion was seen only by PEM. And this was significantly more likely to be malignant if a lesion was seen only by PEM than by MRI. So there are fewer, and you can also see the denominator, there were many fewer patients who had to undergo additional biopsy because of PEM than because of MRI. Although, again, I mentioned at the lesion level, there were slightly more cancers seen. It was slightly more significant, slightly more cancers than it was significantly more. Importantly, though, one of the key points here is that none of these tests were 100% in terms of the lesions that look suspicious being cancer. So you certainly don't want to send a patient straight to surgery without doing additional biopsy to prove that that additional lesion is cancer. And this highlights the need for having preoperative core biopsy. Now, we did not have PEM-guided biopsy until rather late in the protocol, but I want to talk you through that because it's actually a very elegant technique. And this was just published in the Breast Journal in March, and Dr. Kalaniak is the lead author, and she can certainly speak more to it if there are questions. With this, it's very similar to an MRI-guided biopsy. The patient is placed in compression, and between the paddles, there is a needle guide holder. Imaging is performed, and it's seen, you determine which slice the lesion is best seen on, and this was actually a case that I did at our center. Once you've done that, the software helps you determine which of the positions in the needle guide holder you want to use. And just like with MR biopsy, there's a needle guide cube. You would clean the skin, numb it, and then place a trocar, and then get that down to the depth that you think you need. And at that point, rather than placing a gadolinium impregnated tube, you place this germanium-68 line source, which is sterile in sterile casing. And then we obtain a short 2-minute image over the level that we were interested in to confirm that our probe is right next to the lesion that we're targeting. Again, very similar to MRI. And then we perform the sampling, of course, after administering lidocaine. And one of the nice things here is that we're able to immediately confirm that we've removed the lesion. If you still see the lesion, it's very easy to perform additional sampling. And you also, of course, would place a clip at the time of the biopsy. And one of the other really nifty things is that you can do specimen imaging and show that you've got hot spots, you've got your material in your specimens, and then those hot specimens can be placed in a separate cassette and sent to the pathologist with their attention directed to those, just as you would for example, stereotactic biopsy, where you place the calcification-containing specimens in a separate cassette, and it improves the accuracy of their interpretation as well. Overall, when we looked at surgical planning, of these 388 women, 16% had an appropriate change in the surgical management based on MRI, 11% based on PEM, so it's a little more likely with MRI that they would have more disease found, and it was appropriately changed in their surgical planning. And overall, again, they were complementary, with 18% having an appropriate change if you looked at both together, although we're not advocating routinely doing both exams. It's just interesting to note that. And of the mastectomies performed in these patients, overall 56 women had an appropriate mastectomy. 71% were predicted by MRI, 36% by PEM. There were 2 only by PEM, and importantly, there were 25% of women that weren't recognized as needing a mastectomy by either exam. And there were still some unnecessary mastectomies. Overall, 10 that were prompted by MRI and 6 prompted by PEM, including 1 only by PEM. This last part was not significantly different for either. If we look at the size of the cancer on PEM compared to pathology, it's hard, as you may be aware, to size. So we looked specifically at the subgroup of cases where there was a solitary malignancy and less than 10% of it was DCIS. And in that subset of patients, there was a strong correlation with size of histopathology for both modalities, although MRI was significantly more accurate at giving us the final size of the tumor than PEM. I want to just comment a little bit on using PEM to monitor response to neoadjuvant chemotherapy. So early on, Rich Wall in 1993 had published a small series with whole body PET imaging looking at this issue and showed that you could find decreased FDG uptake within 8 days of the first treatment. And this was very exciting and has actually really prompted a lot of the further research in this field. It is important to note that in some subsequent work, there's been only 75% sensitivity to residual primary tumor, only 74% specificity, so it's not perfect, at least with whole body PET, but we do expect better detail with PEM. And I'm just going to show you a few examples because we really don't have a broad literature base in this area with PEM. But here's a patient who had known disease in the right breast that was more extensive than first suspected on PEM. And importantly, she had unsuspected contralateral tumor that was seen on PEM. And she then underwent chemotherapy. And here is the follow-up imaging at the completion of chemotherapy prior to surgery. You can see dramatic response of the right breast cancer, but very little response actually of the left breast cancer. So this is a kind of an interesting case. The next slide shows another case of a patient who had a lump in her left breast. You can see this large area of asymmetry, almost irregular mass. And this was a high-grade invasive ductal cancer with metastatic node. And here, very nice sequential imaging. First, prior to treatment, very intense uptake in the tumor. Even 7 days after the first treatment, you can see a dramatic reduction in FDG uptake. And mind you, I didn't give you all the details, but it is possible to, and very easily done, to draw a region of interest around the cancer and to get a semi-quantitative measure of the FDG uptake in the tumor. We did that in the trial, and we can talk more about that if you're interested in details. But it is certainly something that we do quite easily with PEM. And here at day 14, even further decrease in the FDG uptake in the tumor. So this is a very nice response to treatment. So in conclusion, we now have evidence from a multi-center prospective clinical trial that supports the use of PEM for local staging of breast cancer. It's an alternative to MRI, especially for women who are unable to tolerate an MRI. I think importantly, PEM-guided biopsy is a very elegant and now validated technology and may even be better than MRI. We can talk more about that if you're interested. We have standardized interpretive criteria for PEM. It's been shown to be highly reproducible and with high specificity, so we're unlikely to cause problems for patients as a result of doing the PEM. And so with that, I think I'll turn this over for questions.
Thank you very much, Dr. Burke. That was very engaging.